So I said, please send the notes and the CTG. The CTG was classical. You see sporadic acceleration, but not an active and a quiet epoch, not an active and a quiet epoch, from the beginning of labor. So I said this bleeding was present before the mother went into labor. Probably she has some base of the brain malformation with AV malformation. We had to investigate further, and that's what they found. So a case which was supposed to be punished with millions of dollars went out of the window just by observing there was no cyclicity in the CTG trace from the beginning. So cyclicity is quite important for us to remember. Some mistakes can be made. So here is the 41 weeks, 5 days. The mother is in labor. Very bad trace, not well recorded. The baseline is 150. They say vaginal examination fully dilated, contractions not recorded. And suddenly when they're readjusted, the baseline is 120 and good accelerations, but coinciding with the contractions. She's in the second stage. And after 40 minutes, she delivers Apgar score of 0 at birth, 0 at 1 minute. Accelerated trace, the baby has a bad Apgar score. Why? Because they were recording the mother. The mother's heart rate increases in the second stage of labor. The baby's heart rate, because of the contraction and the head going down, it should decelerate. And this has been shown experimentally by recording the maternal heart rate with the contractions in the second stage. The mother's heart rate goes up. Once the baby is delivered, it becomes a straight line. I have delivered a number of cases where I give the baby to the mother, congratulations, the machine is giving the heart rate. The mother asks, have I got another baby? I said, no, silly machine, I stop it. But really, I have been recording the mother. Common in twin pregnancies because the one baby comes to the midline, the second transducer latches onto the maternal pulse, and you can see the two heart rate 140, 150 after the first baby delivered, one goes down and has accelerations with the contractions, and heart rate is continuing after the delivery of the second baby, telling that we have been recording the mother. Here suddenly the baby has gone from fetal heart rate to maternal heart rate. So be aware, accelerations in the second stage can be a problem. Now the toco transducers have a small infrared sensor which can automatically record the maternal heart rate and the fetal heart rate. So you have to have, they are called the smart pulse devices. On the toco itself, they have put it together and it can give you some good readings. So to avoid the problem. Finally, a little bit about the variability. This is called picket fence artifact if you use a scalp electrode if it is very loose. Nowadays with the autocorrelation machines, you can change it and you can get a good track recording. And if you're using a transcutaneous nerve stimulator to pain relief, you must use an ultrasound machine. If you use a scalp electrode, the current can go in and give rise to artifactual variability. There are two exceptions to interpreting CTG. One is actually shallow deceleration less than 15 is an ominous feature in the trace which is not reactive with absent variability. So this is absent variability. This baby is in trouble, stimulating, no response. The second, a normal baseline rate doesn't mean anything. It is that this baby is acidotic because of absent variability and shallow decelerations. This is in a mother, the baby was late booker, hardly any variability, but the baby was moving. That means it is not due to hypoxia, not due to drugs, most likely a major congenital malformation of the brain. So I'll just finish with this one. I've shown you this slide. So these are typical. This is atypical variable. It takes a long time to come. This is what is called combined deceleration or a biphasic deceleration. Here the variability is absent, so this variable deceleration is a worry. Now these three traces that I'm going to show you are problematic. 170, but big decelerations, but the variability is maintained. 170, the variability is gradually going. 170, this is gone completely. So this is the bad trace out of the lot because the variability is the key feature we have to be worried about. So she's a 41 week, she's 3 centimeters dilated. So if all three features are abnormal, accelerations, variability, and the rate, then there is a problem here. So this baby is going to run into trouble and needs delivery. So I won't go into the more details. Maybe when we come back, we have just time. So I'll talk about classification and the important points to remember. So maybe a few minutes for questions and then coffee.
So do we have any questions?
Okay.
That answers it.
Not finished yet, not finished.
Excuse me, sir.
We have a few questions, yes.
Yeah.
Sir.
The chairperson can ask in the meanwhile, just check with the mic.
Okay, the question is about admission CTG. Admission CTG was started in Singapore when I was working there with myself and Inga Maassen, who was my senior research fellow. The reason why we started that was we were delivering 24,000 babies each year, and there were a number of stillbirths in a low-risk labor unit. And we thought the midwives had no time to look into each case in detail, and we thought it was a benefit. But there have been two randomized studies, major, one in Dublin, one in Dundee, which shows it has no benefit in their hands in the UK. But both studies have problems because the numbers are not enough. And the Dublin study especially ruptured the membranes earlier on, and if there's clear LICOR, then they randomize. If there's no LICOR or meconium, they didn't randomize. Whereas the admission CTG is supposed to be done without rupturing the membranes. And the mean cervical dilatation at which they did the membrane rupture was less than 2 centimeters. So many women in the UK won't allow that. So we don't do admission CTG, but I would encourage you to do intelligent auscultation, which is equivalent to an admission CTG. Listen for accelerations with fetal movements.
Another question I would ask about the sleeping pattern which some books mention. So what is it, the sleeping pattern which you are talking of? Is it the same as you were saying as the sleep cycle of the baby? Is it the same thing as the sleeping pattern, or is it the absent or decreased variability which we are talking of?
The quiet epoch I mentioned, active and quiet epoch. The quiet epoch is a sleeping pattern. That means there are reduced variability. So for example, if you start a trace at the beginning of labor and there are no accelerations and the variability is reduced, then you don't have to get worried about that because the baby might be sleeping. The only thing you have to note, if there are contractions, whether there are decelerations or not. So with a sleep pattern, if you don't get decelerations with the contractions, that means you can observe the baby for a longer period.
Thank you, sir.
Hello.
Okay, so the intermittent auscultation we do every 15 minutes for a period of 1 minute soon after a contraction. In the second stage, we do every 5 minutes soon after a contraction for 1 minute. So in many of the UK labour wards, they try to practice that, but depending on the number of midwives available, because it is not feasible on every mother. So if they can't do that in practical terms, they automatically put them on electronic fetal monitor.
Is there any prominent difference in the CTG of early premature baby and a mature baby? I mean, is there any significant difference in the interpretation of these CTGs?
In a preterm baby and a term baby?
Early preterm and mature babies.
Yeah. The babies under 32 weeks, they will have reduced variability compared to a mature baby because the parasympathetic system matures later on. So the variability might not be something which you can see very prominently. But as long as there are no decelerations on the trace, then that is okay. And the accelerations in the preterm period will be only 10 beats for 10 seconds, not 15 beats for 15 seconds. So more and more we rely on Doppler ultrasound and the LICOR volume in the preterm period rather than on the CTG. Once they cross 34, 35 weeks, then CTG becomes part of the testing.
Sir, the use of CTG in all high-risk cases, it is okay, no doubt. But shall it be done in every primary gravida? Means in UK you are performing the CTG in every patient?
I didn't
For
get
every
the question. On primary gravid?
Every patient you are doing CTG in UK? Or is it done in only high-risk cases?
Only in the UK is only high-risk cases. So the nice guidelines, if you look at it, we first categorize the mothers coming into low risk and high risk. If they're high risk, they automatically go to electronic fetal monitoring. If they're in low risk, they go into intermittent auscultation.